Yeah, we do. Yeah.
So, a lot of these guys, you know. All right, well, thank you guys for coming out on a typically Texas
Muggy.
afternoon. So, we are gonna, we're kind of at the point now where, you know, we really want to kind of flesh out any final questions or flesh out if there's other information that you guys are going to need. Now, I know I've got HMA on the phone, but I don't believe they can actually talk to us, so they'll be listening to us. We're going to write these things down up here, and Lorraine and I are just going to kind of tag team it. So I hope that you come prepared with questions, or maybe you don't have any questions, which that would be good too. So I'm going to, oh yeah, go ahead. Yeah, please.
Guys, I just wanted to, this is the Levita News. It's a local newspaper that we see in the neighborhood, in the African American community. But look at the headline. JPS Joint Council, actively engaged. This is good. And I guess this is an object lesson. My sister was a school teacher, and so it was always show and tell. So this is my show and tell. So this shows you what good communications do, and when it seeps down into the community. This I see at my church, when I go to the hairdresser, when I go. You just find it at local places. But this kind of information with John Peter Smith is so helpful. You just don't know how much this means to, not just to the African American community, but when you reach down beyond the regular news to get to people that read this. My show and tell. Thank you.
Well, show.
Yeah, pass it around. So we can.
There you go. Thank you, teacher. Yeah, that is good news. So pass that on to the folks, Scott and Marianne, to whoever's responsible for that. Making those happen, getting that word out is really critical. It's going to be a challenge for us in the future, but we're not going to talk about that one today. Those challenges, we're going to hopefully. I think we all feel like we've had an incredible amount of information downloaded on us, and so we want to see if we're missing anything, because it's time to get down to prioritizing what we want to do. So this is really for the committee, after you've seen and heard so much, and we just want to make sure there are no gaps before we get to the prioritization, which we hope will be, we plan it to be, our next meeting, unless we really find out some big-time surprises today. We're also going to, at the end of this meeting, we're going to pass out some information for you to hand out. I think GK staff has prepared some stuff, and it's got basically summary information of what the consultants have recommended, and kind of broken it down into the different pieces. So,
But guys, we both mutually thought that this would be a time for us as a committee. Randy and I really felt strongly about this, that we needed the time as a committee to kind of hear from you individually. So we'll kind of do a little light polling with you, just to, this is a, you know how you check the oil in the car and you put the dipstick in to see if you're half quart low or a whole quart low? This is the dipstick exercise to see where we are with each of you. And for us, it's very important as we move forward, because if you need more information, if you have something that you're slightly concerned about, today is the day that we want you to feel comfortable to say, I got a little concerned about this. I want to know a little bit more about that, so we can help it. Because the next few meetings, we're down on the downward slope now. So we're just trying to make sure that we haven't missed anything.
Yeah.
Okay.
Yep. Thank you.
Thank you.
All right. So I'm going to put my horrible handwriting skills to work here.
Oh.
And oh, are you going to do it for me? Oh, you're so sweet. Oh, thank you. Well, Lonnie probably was already told about how I could have been a doctor, Stewart, is what I've been told, just by my writing, not by the brain, but by the writing. So this is actually a good thing. So I think the best thing to do is just start off with kind of a, round table. I'll start with Mark, and we're just going to kind of go around, and I want you to just let us know. And if you give us the category, and Lonnie will write it up there. So Mark, start us off.
Randy, thank you. First of all, I'd like to know, some of my comments are going to be about information I just still need to see.
Okay.
And one of those is the bonding capacity of the hospital district. So I don't know what can be bonded on the hospital district with no tax increase. So I'd like to know that number. And I guess that somebody's going to do a financial analysis of that. Okay, what can be borrowed at zero tax increase, and then what amount can be borrowed at each 1%, just do a 1% increment of tax increase, so then we could just add that to it. So what does an extra 1% tax increase get you? So if I have those two numbers, then we actually have a way of figuring out what capital is available and at what cost. And I don't know whether that's something that the JPS needs to calculate or if it's something the consultant needs to calculate. But that's some critical information. And again, I don't know if that's a concern or a question. That's a question, I guess.
It's a question. I think it's a good question there. Yeah.
So the two numbers would be bonding capacity with zero tax increase, and what, for every 1% tax increase, what can be borrowed. So if you have those two, you can figure out about what you have.
Okay.
I also need a summary of the recommended projects. I mean, the consultant went through a few of those, but they really didn't give us what I was looking for, which was, here's all the projects, here's how they fit on a timeline so that you can actually calculate a cash flow. How does that play out over time? And they were mentioning some of that, but to me, I'd like to see that in some type of presentation. So it's this project at this time, this amount of dollars, so forth, all that totaled up. So I'd like that shown from the consultants in their recommendation. And then I'd also like another one of those versions that was actually the JPS leadership's recommendation. Those may or may not be the same. So I really want the hospital and their operating team to have looked at that and create, if it's the same, that's fine, but it may not be the same. In other words, it may have things in different order. It may have some different things on it. But I'm very interested in hearing the people that run a hospital, what they think they need and when they need it.
Well, along that line, our next meeting, John Peter Smith is going to make a presentation to us as to what their priorities are.
Good.
As far as the timeline, and I don't remember seeing the timeline in all that packet of information, but you are going to get some information today at the end of this meeting to take home with you that will show you each project broken out by cost and how much. So if you want to know what the psych hospital would cost us and how much it's going to cost to add an extra floor to shell it in, that's all going to be in there. But the timeline, I can't remember. Do y'all remember? Do you remember seeing a timeline?
Yeah, I would just picture it. I'm thinking pictures. So
Yeah.
if I just have a line with time on it, and I have a project, and I have a dollar amount that's a cash flow in a certain amount of time, and I look at all that, I can figure out what the order of the priority is that they're recommending, what that cash flow impact is, or the borrowing impact is, and then when I take something out, it retotals. And again, I would like to see that. It's a simple thing to do. I've done it. I'm a consultant myself. I've done it for clients before many times in capital improvement programs. It's a pretty typical thing to do. It's not atypical. And again, I'd like to see the consultants' recommended proposal on that and JPS's. And again, if theirs is the same, that's fine. But I would hope that they may have a different opinion about the order, the timing, what you do. And I'm very interested in seeing theirs with just theirs. I mean, I guess that's Robert and whoever is on his team. Sit down and take that, and here's how they would do it.
Well, just to make you feel better, in our pre-meeting that came up too, that we wanted to hear from JPS. Okay, we've heard from all these people now. Are you guys in line with this too?
Good.
Yeah.
All right. Well, thanks.
So those are great questions.
Those are all I have.
And I agree with you on the timeline thing.
Absolutely.
Yeah. Okay.
Scott is taking copious notes right behind you there.
Okay, Pastor Evans?
All right. A concern or question, maybe this one. I've got about 3 that I wrote down. One is and it was brought up by one of our precinct 2 persons.
Wow.
Knocked it down.
That was obviously
That was
a very
impressive
heavy
point.
question that you asked, Michael.
Hallelujah. All right. Well, this one has to do with the options or strategies to alleviate transportation challenges. For those of us in the outlying areas, what plan does JPS have? What would we be able to articulate when we go back to our given constituency groups in that regard? People I talk to at the church or in the South Arlington, Mansfield area in particular. So I don't know, maybe that's a question, but maybe JPS has thought about this already, and maybe it involves some partnerships, funding between JPS and the local city entities. I'm not saying JPS does all of that on their own, but that they would engage in conversations with the local municipalities about meeting in the middle and somehow getting them to those care centers in South Arlington. I missed that meeting, but I do understand that we're talking about putting one near there. So how do I get them up the road in 10 minutes to those particular locations?
Pastor, are you talking about really indigent people that will have a hard time either financially or that they're so sick that they are going to need transportation of some sort?
Well, more so indigent. I think that if they're really ill, the ambulance, with all due respect, would take care of that. So that would be one.
Okay.
The other is, we asked during the last meeting regarding comparisons to look at. For example, we capture here in Tarrant County about 26%, I think, of those who are eligible for the indigent care. Well, that in comparison then to what? How are we doing? Again, these help us to market, to talk about what we're hoping to do. So we can say, well, we're doing just as good as Tarrant, Bexar County, or not, as we're reaching in, touching individuals, because these people are voters, or can be mobilized to vote. And the other is, again, I don't know if it's a question or concern, but what are our plans? I mentioned this a couple of times. What are our plans to utilize existing brick and mortar structures rather than JPS having to pay the dollars to build these structures? I mean, when the Affordable Care Act was passed, people were building these emergency care units all over the place. Well, now, in particular in Mansfield, they're abandoning them. And we've had some of the other hospital entities have moved into a couple of them. But we have some real nice ones right along 287, right along the drive path. So that would save some dollars. Let me go on record to say, I do believe, though, that we do need funds to bring the main campus up to snuff, up to date. I do believe that. All right. I think that it needs to be a this and that approach. I think that main campus is very important. I think if we do it right, and it's really nice, it'll be a draw, a recruiting tool for doctors and otherwise. But these three things, though, I think, for me, need to be addressed, and also our work in regard to education of the masses as it concerns preventative care, that kind of thing. That's important, and JPS working with. Again, this isn't something JPS will do all on its own. I know it's doing some of this, but working with some nonprofits that already do this and maybe seeding money into those entities to help them to do better what they're doing now. So I guess that was 4 things. So,
Okay.
but anyway, so if you're writing that down, what are we doing to partner with existing nonprofits regarding citizen education?
Providers you're talking about now,
right.
nonprofit providers.
That's what I mean,
yeah.
That's my 5 cents.
Okay. And as Lonnie's writing this up there, if it doesn't look like it actually is saying what you did say, let us know so we can modify that slightly, because we're going to get all this into a written format. We don't want to lead anybody down the wrong way. Scott?
I'll just echo the bond capacity. I think that's an important number of what's the capacity without increasing taxes. And then I guess, what is the threshold or guidance level for, the over and under? I mean, what's the threshold level that we could probably go up to with an anticipation of passing it versus, all in and then losing at the ballot box?
So you, just to make sure I
From a
understand.
political standpoint.
Just, yeah, okay, I wanted to make sure I understood what you were asking. You would like some sort of a expert opinion that this is probably as much as you're gonna be able to
Right.
ask from the taxpayer. Okay,
And how much of that includes a tax increase or not?
But that wouldn't come from HMA or coming.
No,
They're not,
no.
that's something.
no, and I
Has to be
think,
done something.
I think
Probably gonna
GK,
come
wasn't
from-
there some discussion, about using a consultant to help us answer some of those sorts of questions?
Yeah,
Mr. Gavris, I think?
I think there's two paths that we go down. One is a need path, and one is what can we afford path. And so when it gets to the point that if we go and when we go to a bond package, there's a lot of different things that play into something like that. And those of you who've worked bond packages before understand how that happens. I don't know, though, that, I think we need to state what the need is, and then we need to figure out what the revenue streams are that are going to fund the need. And I think when you get to the point of talking about the revenue streams that can fund the need, that's when you get into bonding capacity, that gets into some discussion, though I don't know how much, well, we can go ahead and really realistically think we can pass those type of deals.
I think that's important.
Yeah, I know, and but believe me, that type of analysis has to occur when we begin to put a bond package together. Excuse me. So we're already talking a little bit to some different groups about those type of things, but it's pretty early in the discussion for that particular piece. I know that's not a straightforward answer, but that's
It's
about
not,
as
it's
straight.
very political.
He's a pastor, he just tells us.
No, I just don't.
Gotta watch those.
Just say a prayer for us.
I'm not sure how we're gonna get there, Scott, but in the end, I think
Yeah,
that question will have to be
I think
answered.
those are important numbers
Yes,
for
they
this
are.
committee to have
Yeah.
before we make a recommendation.
It's like knowing it's almost like
And
knowing
part-
what's in your checkbook, yeah.
Yeah.
And I
Okay,
think by the time we get to the final recommendations of the committee, I think we'll have a big majority of that.
okay. Dr. Flynn?
I would have echoed the same thing, so I don't need to rehash that, because as I watch, I view this as three big areas. I think it's the physical structure of a new hospital. I think it's the mental health component, and I think it's the clinics, which then dovetail into the travel issue and everything. So that's how I've just been kind of parsing these in my brain, and as I've been doing the fiscal math, we're well over $1 billion of need. So I do think we have to, at some point, to repeat GK, know where reality is as opposed to our big wish list. And then I would just echo what my colleagues have said, namely a timeline. And then I think it's going to be very important to hear how JPS views this as opposed to how we view it. They're living it every day. So I'm impressed at three big dragons that we have to try to slay here, and they're all big and they're all very expensive.
Yes, they are, yeah. Okay, good.
Can I put mine in?
I'm sorry, Lorraine, but no, you may not. Go ahead.
Okay, so.
Go ahead.
I guess my one concern, and I share everybody's angst, and the questions are great. Do you know the one thing that bothers me? We can do all this, we can build the hospitals, and we can get our behavioral, where are we gonna get the people to do that? The training, the staff, if we keep saying that our population's gonna increase, where do we get the folks? and train the doctors to fill this capacity. That's my,
If it makes you feel any better,
please make me feel better.
okay. We have had that issue for 40 years, really, seriously.
Okay.
And it will be a challenge, though. It for sure will be a challenge. But it is a challenge that the medical community has been able to, for the most part, been able to produce enough nurses, enough doctors, enough technologists. Will it be enough for this ferocious growth? I don't know. I don't know. I've been in other ferocious growth markets. But even if you didn't produce another nurse or produce another doctor, which we know we will, but let's just take the worst case scenario. If we didn't produce one, I think by doing what we're doing, we will be utilizing what talent we have now in a better way than a very inefficient operation that we've got. So, but I mean, I think that's legit, but I think that every medical community, and you know, Dr. Flynn, certainly you are the expert at this, certainly chime in here, but it seems like every community is wrestling with how are we going to get enough nurses and doctors, and that's why you have now physician assistant programs and nurse practitioners, and as we try to get the extenders out there to, Stuart, I don't know if you want to add on to that, but
Yeah, I would, I actually am not a glass half full kind of person, but this one I'm pretty much half full. I do think we're training the physician workforce. I think we need to increase graduate medical education in Tarrant County, and there's some really serious discussions in that regard. It's a place that people don't want to leave, so once they come here, they want to stay, and that's a beautiful thing, and I've been here a year, and I can just feel that every place I go. We have huge nursing schools within a 30-mile radius of here, so we ought to be producing that part and keeping them. And then lastly, I think a major asset to this county is the Tarrant County Community College.
Yeah.
Yes, I was just getting ready to go there.
Yeah.
And that is just
Yeah.
a huge
Just saying.
foundation. So I actually think,
Yeah.
not only do we have all the building blocks, but if we're going to add 50% to this population by 2030 or whatever the projection is, a portion of those will be workforce moving in here. And then I'll just say, and it's not an infomercial, I am always amazed at public hospitals and the individuals that work at those. And boy, JPS is no exception, from the physician and the nursing staff. So this is really a half full. Now we have to congeal it and make it happen. But what I don't want to do in the medical physician category is train them and then have them all have to leave
Yeah.
within a small, because we won't get a return on that investment. And that's both for TCOM and the new medical school.
yeah. Does that make you feel a little bit better?
I feel a little bit better, but it just,
Yeah.
and it,
It's legit.
but it feeds into probably my next concern is when I first went into John Peter Smith, when we did the tour, I probably had not been in a hospital in 50 years, and I'm 29. But what I got the sense of as we toured was piecemeal. We did something 10 years ago, and we saw that, and then we did something else over here, and then we did something else over there.
Agreed.
How can we actually make this or is what we're attempting to do going to be a real coordinated effort, not just for John Peter Smith, but for Tarrant County? I don't see how it can work unless there is some coordination. I know we said there's gonna be more, one of the recommendations is more coordination with
The
the
other
hospital.
providers and such, yeah.
But how do we actually make that a reality instead of just saying it on a piece of paper? That's my concern, because I think we will spend a lot of dollars, and it will be for John Peter Smith. But how do we make sure that this is a holistic approach for Tarrant County's health community?
Okay, did you,
Now shut up.
can you put that all into one sentence?
Me speak is too much.
No, you didn't. So, want to, how do you want to condense that for
A
her?
holistic health approach for the county.
Okay. Thank you. I think those are all good concerns. Dee?
I'll try not to repeat. The way I've interpreted what we've done, we've got a whole lot of data, and I would say it's fairly clinical. There are these needs out in the community, just on averages. They're not really Tarrant County centric. They're kind of based on a lot of other numbers the consultants have come up with. So I think I understand that. Big need, overwhelming need. Then I've kind of probed Commissioner Wynn and Commissioner Brooks during the meetings, trying to figure out, I want to understand the vision of the county for what we're trying to do. And I think, to put it very succinctly, we're trying to make the county healthier.
Right.
So these two things are there, and I'm trying to see how do we get here. And I think it's back to the boots on the ground. I got to know what the people that are doing the work in the community need in order to marry those two issues. And I think that's the question I have. I don't think I've heard that.
Okay.
And I need to know what they think the money would be best spent in order to improve the quality of healthcare in Tarrant County, deliverability, and all those issues that we're hearing we're deficient in. We're not going to be able to do everything.
Right.
So what can we do well and really improve the county? And maybe at that point, we marry the bond package, because then there's a need
Yeah.
within the county to do that.
So I think I heard two, though. You want to know the vision from the commissioners, right?
Well, I
And
think
you
I understand
also-
that, because Commissioner Brooks and Commissioner Wynn have.
So you feel like you've got
I
that one
think
down?
they've said
Okay.
it as much as they
Okay.
can without
Okay.
expressing it for the whole commission. But we're put here to assist the commissioners to the extent we
Yes.
can. But I still think I need to understand what would advance the ball most with these dollars that we have, because we can't do all those things we've seen.
Yeah.
Otherwise, we'd bankrupt the county. So-
Yeah, yeah, okay,
And I just don't think I understand that yet.
okay.
What would improve the healthcare in the county most, and where do we need to prioritize those dollars based on professionals who are seeing it every day in the field?
Okay. She's got that on there. Tisa?
Well, it looks like all my ideas and my questions are taken at this point. I hate to piggyback, but
okay.
when I was going back and researching the history, the historical context of the bond, it seems as if, based on some of the feedback from the constituents, was the psychiatric hospitals. I feel very comfortable in our recommendations and our conversations back and forth, that's reflective of what the community expressed, and also an increase of beds. So my question is, and reading newspaper clippings and not knowing, I did not watch every commissioner's court meeting, I admit, but just to see how it got to where we are today, because I feel like some of this must have been talked about when it was originally presented to the commissioner's court. I'm having difficulty understanding where we are now, how that correlates, and what the missing gaps were to where citizens' commission needed to be formulated in order to, or committee was formulated in order to kind of vet things, because I think the pros kind of know. So I'm just wondering what were those questions that were lingering so that we're able to answer those questions?
You're talking about from the initial proposal?
Correct, from the initial proposal,
Yeah.
correct.
And from previous ones, does it look like since 2000 we've been doing this?
2015,
or something.
2015, from as far back as if I was able to research, yeah.
Yeah, okay, good question. Dr. Lowry?
Gosh, I made a couple of notes. I think synergy is an important word for us and to try to get to the community. JPS has come to this point without a great deal of help, and I want to expand on that in the sense that just a few years back, if you went to JPS and you had a heart problem and you needed heart surgery, you got shipped to Galveston. We didn't have it. So JPS has, without, thank you very much, bond actions, developed. We developed a heart program with a cath lab that has door-to-cath lab times that are remarkable. JPS has come a long way without help. If I were JPS leadership, I would be perhaps saying, watch how much more we can do when there will be help. You know, there are for sure going to be some people that are against this bond. No matter, there'll be people against it because it costs money. We all agree on that. So we need to build on the synergy of what can we do to help you folks see that we've done all this without help from a bond fund. With a bond fund, we think we can do better still, okay? That's a concern I guess I have. Second concern was how do we deal with the option that's failing to pass? And I think for this hospital and this system right now, failure is just not an option. If this thing fails on the bond fund level, we're gonna be stuck in the same mire and whatever. I believe the JPS leadership is way different from what it's been before, and I'm not talking about me, I'm talking about the employed people over there. I'm a fairly newbie to the board group, right, DT? We're all newbies fairly much. So, we can't let this not pass. We've got to find a way that the public understands the importance of this behavioral health and how many people and how much law enforcement's going to be involved if we don't take care of it. One more quick item, education. Dr. Flynn, I'll refer to you. We're working on it. The reflection that we see in the mirror at JPS is that we got a ways to go. We have an outstanding family practice residency. I guess most everybody in the community knows about it. My son's an ER doc, and he said if he was going to do family practice, he would have fought to get in the JPS program. It's outstanding. And yet, the nucleus of a medical community is programs like internal medicine. We don't have an internal medicine residency. We're working on that. We're developing new chairs and that sort of thing. So we've got an awful lot to build on and yet a long way to go in the way of education, but we're going to be a critical part of the next phase, if you will, of education. And I guess lastly, the thing I'll say is I think, again, if I were JPS leadership, I'd represent JPS as a bridge from the past. The past was JPS takes what they can get and they just smile and go on to the future of healthcare in Tarrant County. And I think if you watch, JPS has potential to be more of a leader than it's ever been. Did I say anything that was a question or concern? Maybe not, but those are my concerns. I just think we can't let this not pass on some level. How do you go to the public? I'll let the county commissioners tell me. How do you go to the public and say, well, how much of this will y'all accept? You know, we just don't want no.
Right.
No is not what we want. No's the wrong answer.
Okay.
I'm done.
Okay. Thanks, Roy.
Okay, I read through the HMA report, and especially among the various recommendations, there is a common theme, and it really resoundingly echoing in my mind. The HMA consultant said, make this one statement, and it stands out in my mind, that the need is so great that even if JPS, and if we continue down the same path that we have been doing in the past decade or two, even if we work together as a community of healthcare providers, we would only be able to meet about 60 to 75% of the needs. So the theme of the recommendations revolves around prevention, revolving around wellness, which is what you stated up there, Madam Chair, about the holistic health approach for the county. So that's my concern. So that leads me to a question: does JPS has the capacity or the capability or even the interest to take on that recommendation? How do we? Another question is it even JPS's role to do that? Is it their responsibility? Is it a part of JPS's mission? To perpetuate or cultivate a culture of health, of wellness, of prevention, to educate the public about these. We know, based on the recommendation, that even if all the healthcare providers in Tarrant County work together, we would only be able to fulfill 60 to 75% of the indigent care needs, leave alone the entire population. So that means we have to do something different. What is that difference? What is that? And does JPS has the capability or the capacity to do it? And is it even JPS's responsibility? Or is it part of JPS's mission? So that's my first question and concern. The second concern brings me to, am I going too fast, Lana?
No, you're fine.
Okay. It's another statistics that really stand out in my mind was the fact that JPS's penetration rate into the indigent population is about 26%. And if you looked at the targeted JPS connection population, the penetration rate is only 34%, okay? The question is, what does that mean? Standalone, those numbers don't really mean much to me. Comparatively to other like counties, Are we doing better? Are we doing worse? I have no idea. And I asked the same question the last time we met, and I don't think we have an answer for that today or tomorrow. I don't know. Or should I lower my expectation?
No, I think, I don't know if it's in
It's
those
up there.
documents today or
Yeah,
not,
I asked that
but I know that HMA did
Yeah.
provide us some information on
Yeah,
that, comparing us to Bear and
I think you're
Harris.
going to get some of that in a handout today, but we are coming back next time with that
Okay.
analysis that you
Yeah.
requested.
So I think understand how we are doing in relation to other like counties would really give us a different perspective, right? And that lead me to another concern is, JPS is a safety net organization. We are charged with the legal responsibility of providing health care to the indigent population. And I don't think anybody in this room would deny that. But we also know that we don't have enough money and the capacity to handle all the needs of the population. So that means we need to collaborate and partner with other healthcare organizations. And we also have to provide some sort of a portfolio of commercialized services so that we can generate enough revenue to take care of the indigent population over and on top of the tax revenue that we collected. So what is that balance? How do we do that and accomplish our mission and still maintain a relatively healthy relationship and partnership with other healthcare organizations, which we know we need to work with to build that culture of wellness, if you will. So it seems to me that the two needs are conflicting with one another. So that's my concern. What's the strategy to maintain that balance? It's a very delicate balance, but I think we need to recognize that potential conflict that is so much inherent in the nature of JPS business. And lastly, my concern is we tend to focus so much on the tangible, because when you're talking about a bond package, you're talking about buildings, right? That's what we talk about. And the voters, we see just buildings. But we all know it takes more than the tangible. The key to success is in the intangible. So if we just go to the voters and the public and we say, look, we got the solution for healthcare, it is to build bigger buildings, taller buildings, more buildings, they're going to say, how is that going to solve the healthcare needs in Tarrant County? So I'm talking about the tangibles. So my concern is, how are we going to communicate effectively to the public regarding the intangibles? Are we just going to focus and talk about, bond capacity, new buildings, this and that? And I think if we go down that trap, that path, we may fail, as you have mentioned. So I think we have to communicate about the solution, the whole solution, not just the buildings, which is only a very small part of the overall solution.
Yeah.
And that is my concern. Okay.
No, it's a good point. I think if it ends up where the public says this is just about buildings, we'll never make it. They can see good buildings all over the place. They can see big THR and even JPS, it's a big building. But unless you've been in it, you don't realize just how dysfunctional that building is. Those are great points, Commissioner.
I think we have to have this holistic,
Yeah.
we gotta work with the other folks.
Okay. So are you pinch hitting for Trent? Is that
If I
right?
say something that's not right, it's Trent's fault.
I'm sorry, you have introduced yourself to me, and I've forgotten your name. Could you, just for everybody here, could you let everybody know?
Yes, I'm meeting and
And we are not related.
I think about 70% of our population have that last name. Anyway, thanks for having me here. And I'm sorry, I've just jumped in, so I may be missing some points. But I think part of the thing that we need to do or see a better job is the potential cost avoidance. Why are we building this new hospital system?
I don't think they can hear you.
Oh, more potential cost avoidance. Because if you're gonna build just the hospital, then we're missing the outreach program to the people. It can be very costly because you will be missing a lot of stuff along the way until it gets worse. Also, some of the stuff that we do, from the behavioral health program, the substance abuse and all that stuff, if we don't treat and take care of the people there, then we're gonna be practicing healthcare in some other location, like jail or some other places where preferably it's a matter of allocation of tax dollar to do it correctly. I think also understanding, I see the statistic and all that stuff of the population, but we need to understand the statistic of the kind of patient that we tasked to do. And also, by understanding that, we understand the ethnicity, where they come from, with new analytics and new medicines coming out with new stuff all the time. Then we can address some of the question also as well, is that where the people are born, their lifestyle, their socioeconomic, what kind of disease burden are they gonna have so that we can stop the disease progressions in that regard. Preventive is one of them. It's also to help us, in essence, address the healthcare equality and healthcare equity of the underserved population also as well. At some point, things are shifting all the time, right? We're shifting from a privilege to it's the right. So along the way, it's not what you give, how you give it, so that you can avoid a lot of other stuff that happening in other area of the country that we've seen uprise and all that stuff all the time. So I think those are some of the key elements important, of understanding who are you serving, right? If you know that's the population that you're serving, do you know everything about them? How much you spending? What's the total cost of care? How much you spending on inpatient? How much you spend on outpatient psychiatric drug office visit? Do they see the right specialists? Reaching out to make sure that we have, otherwise we're not going to be providing the right care, because if we can't recruit that type of specialist, they're not showing up. If they don't go anywhere else outside our network, then are we providing the right care for them and all that stuff? I think in the next 15, 20 years, it's how much do you know about the population will help you plan better than just, it happened. And then, under the normal operation, we probably can address a lot of needs for our people. But when disaster strikes, where they go, people, place where you have level 1 trauma center, we are the safety net for the whole population, not just the people there. So I think we need to start looking at those things and what if stuff. And I think the other concern I have is that with all this stuff, right, we have TCOM, and then we're going to have a new medical school coming up. What kind of disruption are we providing with all the construction to make sure that we still can provide the business continuity? And how much of that is going to be a one-time cost of allocation of moving people around? And then also, we can be spending $1 billion. We're blessed with a lot of university around us, community college. And then we're also going to have, can we allocate some of that dollar amount? Do we train people that happen to need a different career path, that are on safety net, that we can provide short-term, long-term? I think the university and the community college can help. But for skill, why not pump a portion of that into Tarrant County residents that are employed by these contractors that we're building that the community, and then become taxpayer also as well, have a different career. So I think that opportunity is not, it's concern, but opportunity to do something that can be economic development also as well, not just spending taxpayer money and do something there. So it's exciting, but it still needs to be looked at so that we can better our community also as well.
Thank you, Mr. Nguyen. Appreciate that. Dr. Simmons?
Sir, I'd like to see us get a little bit more, actually quite a bit more input from the providers, the medical departments. We talked a lot about behavioral health. That's one of many service lines of JPS, whether it's family medicine, hospitalist, ER, OB-GYN. All of those are going to have important points and things that they see are going to be needed in the future. That also includes nursing, and it also includes occupational and employee health, which is the department that takes care of everybody taking care of everybody else. And what that's going to need to maintain the workforce of JPS in good health and managing work injuries and things like that. I'd like to get their input on the service lines at JPS, what's available and what's needed.
Sorry about that. I don't know what that is. Well, hope you're okay.
So,
You can't talk back.
as Dr. Lowry mentioned, there was a time when somebody that needed cardiothoracic surgery was taken to Galveston or flown to Galveston. Those were back in my days, and I remember that.
Yeah.
And I remember the days that we didn't have interventional cardiology. We had to transfer those people out. And sometimes not having a service line can actually cost you more than having it when you're dealing with the complications and the things that result from not having that type of care. So I think we need to get some good input on that. The second thing would be the residency programs. I think we need to get input from the people that run those about what we currently have and what they're going to need. That not only provides critical labor to JPS, it also provides your future, because so many of those physicians and nurses and things that train there, if they see the great work environment that JPS is becoming, then a lot of them may like to stay there once they complete. And that actually makes it easier for you to recruit and to retain good people. I'm not sure if any other training programs may need to be added, but that's something that we probably need to look at as well. And finally, looking a little bit more in depth in patients that are in areas that are not easily served by JPS, as Pastor Evans was mentioning. I think we need to look at the cost of care of what we currently incur, what JPS currently incurs to see patients in JPS facilities, and in areas where we don't have the facilities, does it make more sense to take those people and move them to the facility, or does it make more sense to us maybe looking at utilizing local physicians to provide that type of care? And if you can do so at a cost that is similar to what you're doing in the JPS facilities, that might actually make more sense for us to look at doing. Traditionally, that's not really been done at JPS, but we're looking at the future and looking at how we're going to address the need. And there are a lot of physicians around the area, perhaps in the outlying areas, where there are no JPS facilities that might be willing to sign up for that. Those are my three.
Those are great points.
Great.
Thank you, Steve. Dr. Trevino, last one.
Yeah, so I'm in support of what has been mentioned, and I think I'm going to piggyback on what Commissioner Nguyen has also articulated. Because as I was hearing, I said, we focus so much, there's this building, we need this building, and we need this, and we need the capacity. But what we do know is that what the community is going to want is the connection to them. How can we communicate that, how can we get their support so that they feel a connection and make sure, and they feel connected in a way that they know that the healthcare delivery for them or for the community is going to be improved as a result of that new building. Because if they don't see it, they're not going to support this. They got to see that change. They got to see that change. You got to paint that picture. Here's where we are. Imagine this. And they have to connect to that imagine and how their lives or the lives of their neighbor or their loved ones is going to be improved. And that comes, and also is, my concern is that, how are we going to communicate that in a way that they don't feel that we're just placing this burden on them, burden on the taxpayer, is who's behind this. They got to see that this is, who from the county is with them, what business partners are, so that they see, oh, well, it's not just them. They have a plan, here's the plan, and this is the support. The level, as they're working, as the consultant continue to work on the priorities as well as the leadership, I think it's important as they outline it, that we go back into the impact, how many lives saves, what's the level of coordinator care, what's the level of outcomes that we can expect from the leadership and from health outcome as well. Because I think that's gonna be I know that's helpful for me as I prioritize for many, many projects, but from somebody that was heavily involved in the last few years in a major capital project and going and asking and garnering the support of the community, funders, investors, those are the questions. We know you need a new building, but tell me what this building is going to do. Who are the partnerships that you're bringing to create those capacities? What are the pipelines that you're building? What's the prevention level that you're bringing? And so that's important because that's what the community and those supporters are going to connect to rather than just a tangible building.
Yeah. Good, thank you. Randy, you have anything?
Yeah, I just want to make sure, though, that we didn't leave anybody out before I just give a couple of thoughts, and then if anything else came up while the discussion was going on. Okay, I'll just give you you guys have hit almost everything that concerns me, so I'm not going to take you through a recitation of all that again. But I will say the two concerns that I have are, I hope we're not relying too much on this, and I'm trying to remember the phrase that the consultants used, but it was, I'm going to paraphrase here, it was optimal healthcare management, I guess I would say, which is basically a fancy way of saying, we're going to reduce the length of stay because we're going to manage this so much better. And, I hope that's not too Pollyannish. I mean, that's something that I think JPS probably tries to do now anyhow. I mean, every hospital tries to do that. There are great incentives to try to do that. So it would shock me if JPS didn't already try to do that. So, but maybe there's more there than I'm initially seeing. The other thing is, and it comes under, I guess, the unanswered question. And maybe it was buried in all that information, because I just haven't really asked the question, because I haven't seen it. The one area that we have not investigated, and I don't know if this is a good thing or not, but I know in Travis County, which is in Austin, Brackenridge was their equivalent of John Peter Smith. And about 8 to 10 years ago, Austin decided, and they own that hospital, the municipality does, they decided that they were going to partner with Seton Healthcare System. And if you know anything about Austin, they've got two systems. They've got Seton and St. David's. So a little bit different than what we have here, where we have 3 major systems, okay? But what I've never have heard or seen is what has been the result of that partnership. Was that a good thing? Generally, when you partner, one of the things you get is capital out of that. So in other words, part of our biggest fear is where we're going to get the capital to do this. And we talk about partnering all the time. Well, I can just tell you that there's nobody out there sitting out there saying, man, I just can't wait I sure hope that Blue Ribbon Committee has an opportunity for me to partner. That's not going to happen. But there are cases where partnership has occurred, and I would just like to know, and this is going to go back to HMA, I suppose, for them to bring us that information. Is there a private partner out there, THR Baylor, whoever it is? Is that opportunity there to bring us needed capital to do some sort of partnership? What does that entail? I don't know. I just know that they did it down there, and I've never heard anything bad coming out of it, but I've never heard anything good coming out of it. I'm just totally ignorant about it, and I'm sure that Travis County is not the only county that has ever done that. So those are just the two things that I'd want to add without just beating all this stuff to death, because I think everything you guys have brought up is extremely legitimate. And well, actually, I do have one other, and it's just this is where I'm the half empty glass. One of the things we've battled forever and ever in healthcare generally not just JPS, but everybody is, you know, a lot of our health costs are a result of bad decisions made by everybody. Meaning whether it's the food we eat, how much we eat, do we exercise? I mean, there are the category of genetically, this is just the way it happened, but there's also a huge piece on just lifestyle choices that we as a country, we make. And I don't want to be the czar of telling anybody how to behave, but there's a cost associated with it. And I don't want to lay that on John Petersmith, just like I wouldn't want to lay it on Barclay Burdan at THR. There are certain things they can do, but short of getting into somebody's house and saying, we're putting you in jail if you eat another taco, I mean, I just don't know how we're going to see dramatic changes by the population of this county or any county, and it is a key piece of the entire problem of healthcare from coast to coast. And nobody's got the answer on this one, so it's not, and I don't think we should be trying to get that answer. Should we have the education? Of course we should. Should we have the outreach programs? Absolutely. In fact, I know that they've got the outreach programs right now. So is there a lot of time that we need to put as a committee, as a leadership group, to further push John Petersmith on that? I don't know. I don't know if we're going to get a real big ROI on that, because there are minds from the Mayo Clinic to anybody you can think of that have been trying to figure out how do we convince our population to take better care of themselves. Because if you could do that, you're going to lower those costs big time.
We're working on it, Randy.
Yeah, I know, we're working, and you're,
We're working on it.
and it's all good.
Yeah.
I'm just saying that, will we get the dramatic, okay, hey guys, we need 100 less beds because we think we've got this I don't think we're probably going to get that sort of thing. So I kind of worry about how much of that piece we can really, at this level, have an impact. Are we supportive? Absolutely.
Sure.
But I think there has to be a little bit of realism in there too. But anyhow, that's my half-empty glass.
Yeah, I think if I
piece.
can just comment on that, so you've grown up in this and so have I. So I think one of the drivers, it's not gonna change the individual per se, but a driver now is, we are not getting reimbursed, and this is going to continue, for procedures, for caring for disease. We're going to get reimbursed to keep you healthy. So for the first time in medicine, as bizarre as it sounds, and it is just bizarre sounding, that we collectively in medicine and then in society can no longer afford to care for disease. When we have an obesity rate that I don't know what the percentage is, but it's huge. So I'm not sure that driver is us anymore. The driver is going to be reimbursement for health as opposed to health care, which then means, and that's why the whole switch away from hospitals and into the community is taking place. So I don't think we can't force it any faster than any place else. I couldn't agree more with you. I think JPS already is trying, as are the other systems, but this is much bigger than that. And we're about to go through, I think, a real cataclysmic moment in time. If you just to give you an example, interventional cardiologists now make a third of what they made a decade ago. And you can say, well, they were making way too much, and that's a discussion you can make. But the reason they're making a third is they're no longer, the systems are not reimbursing them for the identical procedure they were doing 10 years ago. And we just have one. So we're at a precipice, and there are some real dark outcomes in this, or there might be some real victories in all of this. So I agree with you, but either fortunately or unfortunately, this is kind of out of all of our hands now at this point. We have to get this country healthier. Easy to say, really, really, really hard to do. But if you're not going to reimburse me anymore for doing a procedure, then I'm not even going to want to go into that specialty.
I think that's a key point right
and
there.
There's the other issue. And I watched this for a lot of years of young people. Some chase their dream, and others chase a discipline that helps them pay off their student debt, and have a very, and I don't mean that to be callous, but that is just a reality of the matter.
Stuart, to agree with you, but to talk about where we're going next, I've been in the process of being tied to the JPS leadership and gone to national meetings. And when we started all this value-based care stuff, I'm going to step on the Holy Grail now. That's the newest term now. I can hardly wait to see what the next one's gonna be. Because we've gone through all these phases. You know what, the first day I started in practice, I gave value-based care. I don't care what the government or anybody else says. Value-based care is another term for we're gonna compensate you differently. That is the money. We want you to keep these people well. Okay. So our job, and again, the last thing I'll say is, I'll publicly state again that there's a 26% penetration, Commissioner, into the indigent community, okay? In case it hits the newspapers tonight, I promise you that the three major players in the community are not gonna run out and create a plan to take up that indigent care. And why is that? It's not profit, it's not profitable. That's it. So, that's the challenge.
Yes, sir.
I think one thing that we might want to look at is, I love cars, I'm gonna compare cars. Do we want to build a Toyota reliable, or do we want to put a much more expensive into our community? So, how big and how expensive, because the more, or do we want to go with reliable like Toyota, less maintenance, keep working, because people will be reckless with their health for generations,
Yes.
even though what we want to do. And what I'm concerned is that if we're not careful, then we're gonna limit care in essence, because it's too expensive to take care of the population, especially when you transform into a more outreach program to upgrade the health of the population, because you don't see the end result maybe a few years out.
Yes.
And you don't have to do that. And who's there to measure that? And then you start seeing the limit, the rationing of care if we're not careful.
Oh, yeah, yeah. Okay, so hearing no other input from the committee, I guess we've got some information for them. Is that right, Lonnie? We're gonna give them packets. Can we, do you have the packets? Okay, and this is not nearly as big as the stuff that's in your binders.
And
Much,
I guess,
yeah.
Scott, do you have what you need, since I'm sure you're gonna be helping prepare whoever comes to us from JPS? Are there any
Appreciate everyone's
clarification?
input, and I think we've got some good issues to think about. Thank you.
Well, I think this is very illuminating. At first, I thought a lot of us were sitting here not really paying attention, but we were paying attention. That's obviously clear, and Randy and I, we appreciate
Yeah,
that, because
definitely,
that really makes a difference. So now the rubber meets the road here, and we're gonna have to start making some choices and some prioritizing of how we do things and what is important. Commissioner, I think you kind of hit it on the nail. And Dr. Stewart, Dr. Flynn, everybody made some good points. To mark on the end, you started it out really well, going to the juggler. What we're gonna actually have to deal with. What's next?
Well, I think what's next is, you've got that packet, and at the next meeting, it's gonna be time to start prioritizing, and we're gonna, I think it's Lori that's actually gonna, from HMA, that's gonna be the facilitator. See if I can get GK's attention here for just a second. It is Lori, right? She is gonna be our facilitator, to help prioritize? She is? Okay, yeah.
And we will also send out the comparison, data that you all requested. We do have it. We'll just send it out electronically.
Okay.
As well as a copy of this.
Okay.
Before, the reason I think we might have cut off a little bit of the information on these sheets. So We didn't cut anything
It's
off?
just right on the head. I was making sure there wasn't something over there.
But we'll
Yeah.
also send it out electronically.
Okay.
Yeah, it is on mine.
So we're gonna go ahead and let's send it out electronically
Yes, sir.
again, so you'll receive this again electronically. That way, we'll make sure everything's in there. Next time around, one of the things that we had planned was for JPS to come to us and tell us, that we've heard recommendations from HMA and Cummings is going to deliver their final report also. But to have JPS come and tell us what they believe that their priorities are. I think that was something that we raised today, and so we're going to begin to answer some of those things. We've got a lot of material here. We're gonna start formulating some additional presentations and everything. Working with the two co-chairs, I know that y'all have been in this process a long time, and it's time to now bring it to a head. So that's going to be our focus. We've given you a tremendous amount of information, and quite frankly, today I think was one of the better meetings because we found out what you all really think. And so we're going to take that and begin to shape that. But you're going to hear a lot more information and presentations. Commissioner Wynn, you had asked for some analysis. I don't know if it's in this, but we're going to give you that analysis next week as comparative analysis to other big hospitals. And we've seen that. We'll start working on the bonding capacity issue, though that's not going to be ready for another week, a couple of weeks, or it may be later on. But we're going to try to make sure we answer everything that you all raised. There's some things that we're not going to be able to answer because when you talk about communication issues, those are extremely important things. To develop a communication strategy that's going to encompass the entire county, that's a monumental task. And everybody's been trying to do that for such a long time. So I don't know if that's going to be an end result, but it can be something as a takeaway as we move forward to the end. So.
GK, what would you think about a recommendation of this committee that just said you county consider hiring a consultant to help on the political side of this bond, communicating, and so forth, kind of create the strategy? I mean, that could be something that can address business.
Yeah, and believe me, when we get to that point in the deal, then it's those things are going to happen. Because if we don't do that, if you don't do something like that, you're not going to be successful in your bond package.
Yeah, is there some overall picture of where all the other healthcare systems in Tarrant County believe we should be going?
The one thing when HMA did their analysis, they did the one-on-ones, and they spoke with all the presidents, all the CEOs of all the different hospitals, and I would think that would be something we would need to ask HMA, because I know they did a roundtable with the presidents of all the different elements of the hospitals, like THR, the different hospitals, so that they had a better understanding as to where the not just the private nonprofits, but all the hospitals thought what JPS needed to be, or where the county needed to be as related to healthcare.
Oh, so that's in some of.
I don't know if it's in some, but it's something we can ask HMA to come forward.
If somebody could compile that, this is not a 9-page dossier, but just a summary of where they think we ought to be doing that. I think that would help.
I don't think there's
It's
comments
in the
attributable
appendix of
to the
the final
participants,
report.
but they did have those
The
conversations.
appendix of the final
We
report.
can pull it out for you.
Oh,
Yeah,
no. If it's in the appendix of the final report, I'll get it. Thank you.
And along that note, do you know when they did those interviews, to kind of follow along with Dr. Simmons was asking about residency directors and education directors from, I suspect you were talking about like some of the nursing schools around here as well as the residency programs. And don't let me put words in your mouth, but were any of those folks in that? They were. Okay.
So those discussions are going on quite substantively under the surface with many of the providers in Tarrant County to probably probably add twice of what JPS has in addition to JPS and in conjunction with JPS for residency training. So those conversations are happening at a very robust pace. They're just not ready for prime time because they have a lot of issues attached to them, but kind of a consortium model of GME with JPS, one of the players in a consortium model.
Do
But
we
it
know-
allows you to take advantage of the wealth of training opportunities
Yeah.
as opposed to single entities, which
Yeah.
really is quite limiting.
Yeah. Do you know, in those discussions, have they dialogued with Tarrant County Medical Society?
Mhm.
Okay. So we feel like the private practitioners are getting their input too then?
Yeah, and we're just, first of all, trying to get, you have to have the training, so we need the buy-in from the providers and then get the physician workforce, because they're gonna be the teachers at the end of the day.
Yeah. Okay, good.
So, Doc, would you infer from that the medical community in Tarrant County is aware of the crisis we're gonna be facing? And moving,
Well, again, I can only, I'll answer from my personal perspective,
Sure.
because that's all I have. I think the systems are aware of it, because they're spending a lot of money to recruit into them from elsewhere. So they'd like to grow them homegrown, but yes, they are aware of, we all know what the demographics of the physician workforce is, and we know how that's gonna drop off the table real soon with docs retiring, because it's an aging population. And then the workforce is also, for the most part, very receptive in this. When I've seen pushback, both here and elsewhere, it's when I think you might be training people in my discipline that now are going to compete against me, but there's enough of a need here where that is not a very loud voice in Tarrant County.
thank you. Mark, you about to say something?
Stuart, would you agree that Dallas seems to have a nucleus around Parkland that Fort Worth doesn't have? I mean, JPS and Parkland is apples and oranges, and you talk about support. The academic center of the level of Dallas is not matched here in Fort Worth at present, but it will be.
Right, and I think, right, so I will get to grow this up in a very different environment, which I think is infinitely valuable, to be honest, but we're several decades behind what exists over in Dallas.
Absolutely.
But in many ways, based on this conversation, we actually, I would prefer not to be encumbered with how you and I grew up, because that's not where medicine's going. So we get a chance to grow it up very differently here with a very robust public hospital, and then with other partners that want to be a part of this.
And isn't that a perspective that we have to give to the public so that they better understand? Is it, again, in my mind's eye, if we do it in a silo of just JPS and not, this benefits the healthcare in Tarrant County, I think we missed the boat.
Right.
We'll make it a lot harder on ourselves if we're just out there by ourselves.
Yeah.
Okay, well, thank you all for your attention today, and make sure you got a packet, and got your parking card stamped, and we'll see you in 2 weeks for the fun stuff.
Thank you. Thank you.